So my name is John Grainger. I'm a paediatric haematologist based out of Manchester Children's Hospital. Some brief disclosures. I've worked with a couple of pharma companies with regards to setting up clinical trials or monitoring clinical trials. And I'm also an ITP support medical advisor. My talk today is obviously going to focus on paediatric ITP, and I'm going to look through treatments, both in sort of the newly diagnosed and also in the persistent and chronic setting. To kick off, I'm just going to go over what we mean by first and second line therapies, because the terms that are often thrown around that are often sort of confusing. First line treatment really generally refers to rescue treatment when we want to boost the platelet count relatively quickly with the aim of switching off treatment. So with the aim of switching off any bleeding. It's not designed to alter the course of ITP, but just to stop bleeding. And this most commonly will be steroids or immunoglobulin. Second line treatment is quite different. The aim of second line treatment is to boost the platelet count to a safe level for a longer term, or ideally to cure the ITP. The treatments in second line may take a while to be working and are often designed for long-term use. And the most common ones will be eltrombopag, romiplastim and Metoximab, but splenectomy will also fall into that category. Also, when we talk about treatments, a very vital element that's often forgotten about, especially by doctors, is that of supportive therapy. This includes education, information about ITP, access to support groups such as the ITP Support Association, open access to doctors and to nurses for support around the ITP and information about what to do if worried. It includes review by a paediatric haematologist or other ITP expert to provide ongoing treatment and support. It includes getting the patient into school, being able to play and undertake activities normally, and for older children, allowing them to be working safely. Supportive therapy may also include supportive medications such as iron replacement where there's been bleeding, or hormonal treatment, especially in the teenage girls struggling with heavy periods. When we look at our current UK data of what's happening sort of with patients, we see that overall about sort of 22% of patients are receiving some form of treatment or other following the initial presentation. This slide shows the bleeding severity down as we go down the columns for mild, moderate through to severe. And it shows what's been happening in an initial look back that we did between 2007 and 9, and a more recent look back that we did between 2010 and 17. And as you can see, the worse the bleeding severity in general, the lower the platelet count, but that's not clinically significant, and the higher the number of bleeding sites in addition to the skin. And then when we look at who's receiving treatment, we see generally the children who have just mild bleeding, which is largely going to just be skin changes, bruising and petechiae. Only a very small number are needing any therapy. When we look at those with severe bleeding, we would hope this would be around 100% of children receiving some form of treatment, but the current sort of figures are about 2/3. And again, about 1/4 of those with moderate bleeding severity needing treatment. When we look at what treatments these children have been given, we see that if we look at those children who receive no treatment at all at initial presentation, their average platelet count at presentation will be around the 13 × 10⁹. That's rising up to around 61 by 7 days, a week into sort of the course of the disease. And compare this to around a level of 50, which we expect the body to be working normally. You can see that the body is generally normalized to a safe level in a week without any therapy. And then, of course, the platelet count continues to come up. When we give steroids, the platelet count increases a little bit quicker, so it's hitting this sort of 50 mark at around the day 5 to day 7, so a bit quicker than without therapy. However, when we give immunoglobulin, we're at over this 50 mark by sort of 2 days, really confirming that immunoglobulin is probably the best treatment that we've got at getting the platelet count up relatively quickly. Also, when we look out at the 3-month mark, there's a suggestion that the platelet count remains better in those children who have had immunoglobulin early on. This observation and observation by others showing similar sort of results led on to a beautiful Netherlands study that compared the rates of chronic ITP in those children given immunoglobulin early on into the disease. The study was initially aimed at trying to see whether it could prevent chronic ITP. They took children under the age of 16 with a platelet count below 20 who were not having severe bleeding, and they randomized these children between immunoglobulin and watch and monitor. The results actually showed no difference at all between the rates of chronic ITP, with both groups still having persisting ITP at 12 months at around the 10% mark. However, it did show that immunoglobulin was more likely to preserve a platelet count of over 100 up to the 3-month mark, and then from 3 months onwards, there was no difference between the groups. However, one finding which is very, very important is that those children who received immunoglobulin were much less likely to subsequently go on and have a severe bleeding episode. So 8 children in the monitor arm subsequently needed rescue therapy for severe bleeding versus only 1 in the immunoglobulin arm. This included 1 child who had an intracranial hemorrhage, but thankfully all the children made a good response to rescue medication, including the one with the head bleed. When we look at this group in more detail, 7 of the 8 of them who subsequently had the severe bleed had mucosal bleeding, i.e. things like nosebleeds, at the time of presentation, in addition to just the skin changes. Of course, immunoglobulin is not without any risks or harms, and 6 children needed admissions following immunoglobulin, mainly due to the typical headaches or sometimes the fevers that we see after immunoglobulin. So the conclusion was from this study was, despite the study being aimed at looking at seeing if it could reduce chronic ITP, it didn't. However, it did reduce future severe bleeding in those children who initially presented with mucosal bleeding. When we produced the international consensus recommendations guidelines for the treatment of children with ITP, we took this study into consideration and came out with the recommendation that children with moderate or mucosal bleeding should be offered immunoglobulin to subsequently reduce their risk of severe bleeding. Looking at the current UK data, we see that about 97 out of about just under 2,000 children, i.e. about 5%, will present with nosebleeds that go on for about 30 minutes. The number is higher for those who have a shorter duration nosebleed. However, those who had nosebleeds of over 30 minutes were at a higher risk of subsequently having a severe bleed, although the risk was only around 4% compared to sort of the 7% that was seen in the Petite Study. This is unpublished data, but we aim to present this at the British Society of Haematology later this month. Moving on to look at persistent and chronic ITP. So by persistent, we mean ITP that's still going on after 3 months, and by chronic ITP that's still going on over 12 months. But once we've had ITP certainly going on for more than 6 months, the chance of it going away on its own is only about 25%. Once we get to 12 months, the chance of it going away on its own drops to 10 to 20%. So these children are likely still to have persisting ITP for the foreseeable future. And they're going to continue to remain at ongoing risk of bleeding. They're likely to face lifestyle restrictions. And we know from our work and work of others that they will have reduced quality of life. And certainly those who have persistent platelet counts below the 20 to 30 are likely to benefit from intervention. And when we go on to look at what interventions we have to offer, I'm not talking about splenectomy on my slides here, mainly because of the limitations of time. But let's look at rituximab first. In general, when we use rituximab nowadays, we use it in combination with dexamethasone. And this is a study by Jim Basel's group out of Cornell in the US, where they look at rituximab combined with dexamethasone, and they took 33 children. They saw responses only in about 45% of those children. And of those responders, 6 out of 15, so again, about a third of them subsequently relapsed during the 60-month, 5-year follow-up period. And this sort of diagram here looks at what happens if you take a look at boys to begin with, you'll see really the proportion of boys responding is very low, and they generally all are losing their response by about 12 months. Once you start looking at sort of girls, you see a better response rate, but the younger girls again look to be losing their response. Adolescent teenage girls who have had ITP for less than 24 months duration had about a 50% chance of responding and maintaining their response out to 5 years. So again, when we looked at the consensus guidelines, we included this study, and we included rituximab and dexamethasone as an option, especially for teenage girls. But outside of that teenage girl population, it's probably not a treatment that's going to provide any sort of long-term response. I was very fortunate to be involved with some of the TPO studies. Here I'm just going to show some data from the Eltrompopag study. The initial Eltrompopag study was called the Petite Study, and that looked for a singular response, i.e. let's try and get the platelet count to over 50. And here you can see across age groups, the blue bars represent those who have had Eltrompopag. About 60% across all age groups showed a singular response. In the Petite 2 study, we looked at a sustained response, i.e. keeping the platelet count over 50 for 5 of 7 weeks from week 5. And we achieved this in about 40% of children. Again, let's just emphasize that this is an early study where we used very sort of low doses of the Eltrompopag and gradually increased the doses. And again, let's just emphasize that this study actually started in 2010. So when we talk about this being a new treatment, we've been using this in children now for over 10 years. So it's not really new anymore. When we go on just to look a little bit further at what happened with the children receiving Eltrompopag, you can see here the blue line represents the platelet count over time. The orange arm, the group who did not receive Eltrompopag but received dummy medicine, i.e. placebo. Of course, they tended to keep their platelet count level, whereas the Eltrompopag children increased. At this point here, weeks sort of 12 to 14, the patients on placebo could swap over to Eltrompopag, and you see the platelet counts again being sustained. Again, just emphasizing in this study, we were only aiming to bring the platelet count over 50. We don't need to normalize the platelet count because, as I said earlier, a platelet count of over 50, the body will behave normally. And of course, when we look at bleeding, this is quite a busy slide, but if we just look at the bleeding severity here at children entering the study, any bleeding was seen in about 71%, significant bleeding in about a quarter of children. As the study went on, that 71% dropped down to 36%, and the 25% dropped down to 5%. And then those numbers were sustained as the study went on. So not only are you boosting platelets, you're also reducing bleeding, as you would hope to see. I've also been involved with the studies with romiflostim, which basically show the same thing, very similar response rates. The big black bar here represents platelet count over time. The circles represent bleeding, which you can see coming down, and sort of the green bars represent more significant bleeding. So very, very, very similar. So in conclusion from the work that we've done in the TPOs with children, we see response rates in about 60% with both agents and about 40 to 50% maintaining good response rates. There is short-term problems that we need to monitor for. There's a small risk of liver inflammation. You can see iron deficiency, especially with Eltrompopag, And in those children who've received a lot of steroids in the past, you need to monitor the eyes because you can sometimes see early changes in the eyes that potentially could go on to cause cataracts. Long-term problems, similar to what was being seen in adults, there is a risk of blood clots, especially in older children or children who are on medication that could also increase the risk of blood clots, but that risk is very small. We have probably excluded the worry about any bone marrow changes. In the Remiplastim study, we did serial bone marrows after 1 year or 2 years and didn't really see any significant changes. And the important thing to emphasize is that this is not necessarily a medication for life. Up to half of the children will subsequently show resolution of their ITP during treatment, and it's important to watch and monitor for those remissions. When I just move on to what the consensus recommendations came out with for those children with chronic or persistent ITP, we said, of course, that many of the children can be managed with watchful waiting. This will mainly be the children with a platelet count of over the 30 mark, and those children can be treated with steroids or immunoglobulin if needed. But for those children who are having frequent or severe bleeding episodes or have impaired quality of life, they should be referred to a hematologist experienced in these treatments, and the initial treatment option we would recommend would be one of the TPO drugs. And if there's no response to one, consider switching to another. And in adolescent girls, consider the rituximab and dexamethasone, as I've shown you just earlier. Splenectomy, we said, was very rarely indicated in pediatrics, i.e. in children under the age of 16, and certainly shouldn't be done before 5 years of age and within 1 year of the disease onset, if can be avoided. And of course, make sure we've got the right diagnosis of ITP and make sure any vaccinations are up to date if a splenectomy has to be done. Sports and play were a whole section in the consensus recommendations. We emphasised the need for normal attendance in school, the normal activities that any child should be undertaking to keep them physically fit and healthy. Active participation in activities should be encouraged, but higher risk activities will need to be discouraged, or alternatively treatment may need to be given to provide a safe platelet count if such activities are essential for the quality of life of the individual child. Some UK data that we've just published a couple of months ago, which looked at those children who had persistent platelet count under 30 and had reached the 6-month mark. We see about a quarter of them receiving second-line therapy, of which the most common treatment is the TPOs, but rituximab, other immunosuppressants and splenectomy still being done. But the number receiving second-line therapy at 23%, I think, is quite disappointing. And I think we would hope to see, following the publication of these guidelines, a much higher proportion of children being offered second-line therapies who have such a low platelet count. So in conclusion, for newly diagnosed ITP, remember the need for good supportive care, access, keep going in school. Most children, thankfully, will have mild bleeding and will get better very quickly and will not require any treatments. Most children don't need special blood tests or the dreaded bone marrow aspirate. But those children who are having bleeding, especially mucosal bleeding, should be being able to access immunoglobulin or other treatments. We may need to consider more specialist investigations for those who have got such bleeding problems. And once we get to sort of the 3-month and certainly to the 6-month mark, these children need to be seeing a paediatric hematologist who's got experience in treating paediatric ITP and experience with these drugs, and should be being offered second-line therapy, especially if there's impairment of quality of life, fatigue, or frequent bleeding. And we know the TPOs are good and safe with high remission rates in the longer term. We try and avoid splenectomy. And when none of these treatments work, we've got other treatments in the setting of clinical trials. Avatrombopag is another TPO that will be available in clinical trials from the summer, and rilzabrutinib, which you've probably heard about in the adult ITP talks, again will be available for teenagers probably from the summer also. Thank you. Now I think we're taking some questions later on in the session.